I love the presentation today. It's a topic of passion for both of us, neuromodulation. Tell me, Dr. Anderson, you come from a neurosurgical background. How did you get into neuromodulation?
Yeah, that's a good question. And I mean, neuromodulation, it kind of originated within neurosurgery, but you're right, it's not really been very, I don't know, I guess strongly embraced by most neurosurgeons. And I think it's just because we're spending our time doing other surgeries and it kind of gets lost in the background a bit. And I think for me, it's a combination of just who I am and kind of my preferences. This group of patients where surgery doesn't seem to be the right answer, or surgery was attempted and things did not go right, did not go well, and really the emphasis on a functional restoration, right? Mm-hmm. I was always bothered in training when we'd look at this crooked spine, and there was always this big long debate about how do we fix the curvature and how do we get the sagittal balance where we want it and all of these things, and never once in the hour-long conversation and debate did anybody actually talk about what the patient needed, what their goals were, what the outcomes they were looking for. And that just kind of bothered me because it just seemed to be a little bit misguided. And so I think because of that, I did a fellowship in functional neurosurgery, which focuses on functional restoration, and neuromodulation is a big part of that. And then I think just the need. So as I entered practice in the Midwest, and then that's been even further magnified with my relocation to the Mountain West, there is a huge population of patients that are in need of this type of technology. Technology has gotten better, and it's more effective, and I get to see it change people's lives dramatically pretty much every day. And I love the ability to take someone who feels like they have no hope, mm-hmm. and they have no options, and I get to give them a little bit of hope, and I get to give them an option, and to see that outcome then restore their life. See them go back to work, reopen a business that they had closed. I just don't get that anywhere else. So I guess in a lot of ways, I'd say it's somewhat selfish because I get to see amazing life-changing things occur, mm-hmm. and I want that for me, and I'm just glad that the patients give me the chance to do that.
I know, I think it's one of the most gratifying things to meet a patient when they come back from a trial and they have this big smile on their face and say, I don't know how this works, but I know it works. This is awesome. Yeah. What are some of the common indications that we can do neuromodulation for?
Yeah, and those indications are expanding. So historically, it's felt back pain, so people who've had surgeries that didn't go well, complex regional pain syndrome, which is a horrible condition, but fortunately, this has been very effective. And those were kind of the main indications. But now we've started to spread into other areas. Non-surgical back, people who've never had back surgery but need help because they're in so much pain, diabetic neuropathy, and it's understandable that if you have neuropathy that's not from diabetes, this may well still be a great option. And in fact, my experience is that it is, right? So even though there may not be a formal on-label use for that just yet, it's really effective, mm-hmm. for a lot of these pain conditions. We see it for post-thoracotomy issues when you have nerves that have been damaged through procedures, or maybe they've been damaged through infection, like post-herpetic pain. So really anything that causes kind of an inappropriate pain that persists, that there's not a solution for. There's not something you can go in there and fix the problem. Honestly, most of those patients are good responders. And so when it seems like there's no other option and pain is just there, I would at least say it's worth considering this. And there certainly is more evidence for certain things, mm-hmm. But with every month that goes by, there's more and more data mounting that's really expanding our indications.
Yes, and you bring to the forefront about the expanding indications, and I think the reason of science to expand the indications is that we've been able to prove such a good track record for successful outcomes with neuromodulation. What are some of the common perceptions out there in the medical field that we see as we talk about referrals? Because when patients have neuromodulation and that fails, that gets so much more focus than many of the patients who have had successful outcomes. Do you see that too?
I do, and that's kind of always the case, right? One bad outcome will taint 100 good ones. And I think, honestly, most of the time, and I do attract a lot of failed systems. I revise and repair and fix a lot of systems that just really aren't working well for patients. And I would say the majority of the time, it's more of an us problem than it is the technology's problem. Either the leads aren't in the right place, they're not being utilized the way they're supposed to, the patient is struggling to manage the system the way that they're supposed to, they're having trouble charging it. There's a lot of factors that can make it unsuccessful. And I think the perception is, well, you just put it in and you click it on and it works or it doesn't. And that's just absolutely not true. There are so many intricacies that go along with it. So I would say for patients that come into my office who had a system that's not been working, many of them haven't even turned it on for 2 years. And we have a pretty lengthy conversation. We review the imaging, we see what's happening, we see what's going on, and we provide new technology that we didn't have 10 years ago when it was implanted, and we can troubleshoot it. We can do external trials. We can tap into the system they already have and apply new modalities to it. And about 90% of the time, we're successful at making a system that has not work well for that patient. And that's a big change. And that's what I wish people knew, right? Is when they say, oh, I had one of those and it didn't work, right? My patient had one of those and it didn't work. So therefore, 90% of the time when that occurs, it's a problem with us. It's a problem with something's not working the way it's supposed to be, more so than that patient's body somehow is refractory to the actual technology itself. And so that's certainly what I wish, is that it's easy to hear the bad stories, I guess, but there are way more happy people walking around than there are sad ones.
I know, I couldn't agree more. Just for the benefit of our listeners too, could you give us an example of one of your favorite stories of I was able to troubleshoot this and something that was not working for this patient before and now it is, and this is why we need to pay closer attention to some of the technical details as providers.
Yeah, and again, that's pretty common. So I had a patient who, a middle-aged man, he's probably in his late 40s. He had a spine surgery, laminectomy decompression. He did not get good outcomes, had a paddle placed through an open surgery, and that paddle was in for 6-8 years. After 3 or 4 years, it really wasn't providing a lot of benefit. He thinks maybe 10-20%, and he kept seeking care. As soon as the paddle was in there, a lot of providers say, I'm not touching that, it's too dangerous, it's too risky to get involved. And he was then seen by a few surgeons, and he ended up undergoing 2 additional spine surgeries, fusion, and then an extension of the fusion, trying to treat this pain. And he didn't do any better. He didn't get any better with surgeries, and he was sent to me to kind of troubleshoot the system. And I asked him when he showed up, I said, hey, when was the last time you met with the device rep? And he said, oh, it's been 5 years. And I said, so you didn't meet with them before your surgeries, like in between your surgeries? And he was like, no, that was never suggested. And so I picked up the phone, called the rep, they came, met with him, and just with the knowledge of how to use the system, the improvement that had occurred over the last few years, they were able to capture about 40 to 50% relief using this same system that he's had in for a decade. And that in and of itself was better relief than he'd had ever, even with the surgeries. And then we followed him for several months, and that seemed to be where he plateaued, was around that 40-50%. And so we did what I call a hybrid trial, where I connected to the paddle leads, tunneled them out of his body, and then placed new percutaneous leads above the paddle, was able to drive them and place them above. And because I felt that the paddle was placed a little too low to get the back pain he was looking for, because back when it was implanted, that's where we thought it needed to go, and we've learned a lot. And by doing that combination, it worked really well. He was getting 85-90% relief, and we went ahead and revised his system, updated it with the new technology, and put it in the location where it was more effective, and now he's super happy, living a great life that he's sought for 10 years and underwent numerous surgeries to try to achieve. And so, an old system, you can't say, well, stimulation didn't work for me 15 years ago, so it's not an option now. That's just totally false.
Yes, and I think as the technology emerges and there's more evidence from papers published, we used to think it was called dorsal column stimulation. It's not called dorsal column stimulation anymore, just because we have options that are doing a lot of excitatory inhibition, or exciting some of the other neuronal systems. So a lot to understand about the nuances rather than just turning on the system.
Yeah.
I loved another point that you mentioned during your talk, which was using this in a part of the algorithm of patient care, right? Because I think many years ago when the stimulators came into vogue, one of the things was, okay, it'll be a rescue as a post-surgical tool. We will not put a stimulator for a patient with neuropathic pain in their lower extremity till they've had a surgical intervention done to fix the problem. There is so much focus on trying to fix the problem. In fact, any kind of intervention, whether it is non-surgical or surgical, I do think that it's part of an algorithm, right? It's a management strategy that is appropriate for that particular diagnosis. So I love that you mentioned that as part of an algorithmic approach. Where would you recommend as to how we plug these particular therapies, especially with neuromodulation, into the patient care algorithm?
Yeah, I think it's unique to the patient. And going all the way back to what bothered me about a lot of conventional spine surgery talk is, what does the patient need, right? And so for one patient, really trying to get that fix or that repair may be more appropriate, whereas for another patient with the exact same problem, who maybe is 84 years old, has a history of recovery from breast cancer, metastatic disease, all sorts of issues, it's a different situation. And so even with the same pathology, neuromodulation may be more appropriate sooner in one patient than another. And so I think you have to listen to the patient and you have to figure out what's actually wrong with them, what actually do they need, and then how do we best meet that need. And you're right, it's a challenge to get these things approved through insurance companies who really want to focus on a very absolute objective point. And the problem is that just doesn't apply to all patients. And so I think as a fellowship trained spine surgeon and a fellowship functional neurosurgeon, I think the advantage is that I actually provide all of those solutions. So like you said, they want you to do a surgery. So when I talk to an insurance company and I say, okay, so let me get this straight, you want me to do a surgery that I don't think is going to be beneficial, that I think is going to be a negative thing for this patient, before you'll let me do the treatment that I think is actually going to be beneficial for the patient. And that's a hard question for them to answer, right?
Yeah.
And so I think that's allowed the pendulum to change just a little bit. And as the data is starting to collect, we're seeing good outcomes that don't require these failed surgeries before we can get the okay to do this. And from a cost standpoint, preventing that failed surgery and then the long-term management that's going to be required. These patients leave the office and for the most part, don't really return, because now that you've given them a way to manage this, they're not coming in for repetitive medication adjustments and changes, procedures, or any of these other issues. And they're more productive, they're happier, they sleep better, all of the things that we're trying to get for our patients. So I think if you really think about it from a patient standpoint, then where it fits in their algorithm makes a lot more sense. And there's no question it's much sooner now than it used to be.
Yes, agreed. And I think insurance companies adapting the therapy a little bit more has been helpful. Cost being one of the factors that always comes into play. When I did my fellowship, I actually collected data, part of a whole 5 or 6 year retrospective data collection for my mentor, Dr. Mikhail. He presented at NANS the following year about cost effectiveness for spinal cord stimulation in managing diabetic peripheral neuropathy with spinal cord stimulation. So collected data, and essentially when you're throwing gabapentin, Lyrica, buprenorphine, or Percocet, or any of these other Cymbalta, all these additional management algorithms, as well as repetitive office visits for the patients to come back and say, yes, my pain is not better controlled. So apparently, compared to the patient getting a spinal cord stimulation versus trying to optimize these non-neuromodulation therapies, tends to break even at about 2 years. However, you get more sustained relief. I know that I have diabetic peripheral neuropathy patients that I've implanted a few years ago who continue to do well. I have to ask you, what is your favorite location or indication to place the stimulator for?
That's a good one. So I think like most providers, we like the challenge and we like the things that are a little bit offbeat. I do quite a bit of cervical lead placement, and so the outcomes are really strong. Upper extremity CRPS is really rewarding to see. I would say, to be honest, I've had quite a bit of success with like post-transverse myelitis, spinal cord injury type patients, and those are probably my favorite because that's where the most, I guess that's where most of the naysaying exists, right? In patients who have like a partial spinal cord injury and they have horrible pain as a result, and it's atypical pain, it's multifactorial, it's in multiple locations. And so for me to be able to go into to like the neck and be able to treat chest pain, leg pain by targeting the fibers that are traversing, through this area of injury and above, it's a very exciting thing. And these are in patients who really have a big problem, and they have a really tough life because of something that's happened to them. And so I think being able to give them back some of that quality of life is the most rewarding for me. So I would say that's probably my favorite patient population, or the kind of spinal cord injury patients. But it's kind of hard because it's amazing to see, even the ones that are relatively routine. It's just amazing. It's fun to be part of, what gives them joy back.
Yeah, and I think there's joy in the way we see patients respond, and the procedure is a fun little technique with very few downside or downtime. So this is, I'm very happy that we got to talk about it this morning.
Thank you so much.
And I couldn't talk to a better person about neuromodulation. So
thank you so much. I appreciate it.